Yeah, Sudhanshu.
Hello, hi guys. If you guys can hear me out of that, please let me know. Thank you.
Yes, ma'am, you're visible.
Thank you. I'm just going to try and see if I can. I'm going to have to quit because I just gave it the permission. So I'll join back, okay?
Yes, ma'am. Okay, sure.
Thanks. Right. Hi, hello. I think
Hello,
I'm
ma'am.
good. Hi. Right. I think I'll just make sure that I can share.
Minutes.
Yeah, sure. Perfect.
Okay.
Let me just see if I can. Yeah. Okay, Sudhanshu, if you can confirm, can you see my slides?
Yes, ma'am, your slides are visible.
Perfect, great.
Hello, guys. So we'll be starting with the event soon. Please tell your friends to. Now, today's session will be on, as our week specified earlier, on the eye. Okay. Hello. Is there any disturbance?
I can hear you fine, Sudhanshu. I hope the others can too.
Okay, great. Okay, just give me a minute, ma'am.
That's okay. Perfectly fine.
Okay, ma'am.
Right.
So, as specified earlier, today we have the we have with us today here Dr. Neha. Hello, ma'am. I'm getting an
Yeah.
echo.
Hi.
Is it? Do you have your on speaker?
Yes, mine is put on speaker. Would you like me to change that to something?
Yes, ma'am. Could you get? Is it possible for you to arrange a earphone and microphone?
Yeah. Give me a second, and
Yes, sure, ma'am.
you guys can speak while, and I'll just get something. Yeah. Hold on.
Yes, ma'am. Sure. So, guys, we'll be waiting for another 5 minutes. Please to tell your friends to join in if anybody's left out.
Hello, Sudhanshu. Is this better?
Yes, I feel it's. Yes, ma'am. It's much better.
Better? Better? Yeah. Okay. Perfect. Great. Yeah.
So, she is an alumni of MGM Medical College. She's done her MS under Dr. Abidi. She's a cataract specialist and has done a fellowship also. And she's worked at the Sankara Eye Hospital. Currently, Dr. Neha Dhiware works at MGM Hospital, Vashi, along with Reliance Hospital. So, we'll be starting with, today we'll be continuing our session on the eye. and we'll be just having that. And Dr. Neha Dhiware ma'am has created a special uh, PPT for a very good learning session that we're going to have today. Now, before we start with the session, I just have one line to say that the face is a picture of the mind, where the eyes are the interpreter. So, as eyes play an important role in our life because we perceive everything through what we see, it is very important to know and to correct if any abnormality or any the eye. And from here on, I'll hand over it to you, Dr. Neha ma'am. You can continue with your session.
Thank you so much, Sudhanshu. Before we get started, let me just say that I'm so impressed with, this is a huge chunk of people. How many people do we have here right now?
Right now, we have almost 50 people.
46,
and
almost 50 people. Yeah. So, I
yes,
mean,
ma'am, and more will be
50
joining in
people
soon.
is, yeah, 50 itself is an impressive number for a Friday evening post your regular, college hours. And it's a Diwali weekend at that. So you guys must be really studious. Really happy to have so many of you here. And well, I guess without further ado, let's get started. The brief given to me by Sudhanshu and by Dr. Gayatri was that this is a lecture that I'm taking for a bunch of you who are from the first year to the final year, right? So I was kind of racking my brain about what can I do that keeps such a wide spectrum, in the audience engaged, because it's very difficult to kind of gauge what a first year student would know and understand about the eye. And obviously, a final year student has a much wider perspective. So what you're looking at would be very different. But I think the one thing that all of us have in common, right from the time that we actually get into and kind of step into medical school, is simply that you are always giving free advice to your friends and family, right? From the day you just start your MBBS, people start thinking of you as the doctor, and then you get to answer questions from everything, like my little finger has been itching since this morning to contraceptives and stuff like that. So yeah, it's crazy, but it's the season where the seasons are changing and there's a lot of pollution, and there are just so many things going on that this "Are yaar meri aankh lal hai" is a question that I get asked very often, and I'm sure that at some point in your career you're going to be asked such questions too, right? And that is why today's presentation is titled Bro, My Eye is Red. And what we're going to discuss is a red eye, but a little beyond a question bank. So as I go along, you'll be looking at a couple of pictures and maybe a short history. And if you can guess and put stuff in the chat box, or even tell someone or tell Sudhanshu, or you could just speak up, we'll see if you guys are getting these things right or wrong, and whether or not you can be that telemedicine caregiver to your friends and family, right? So let's get started. And what you're looking at now is, I hope you can see that. And this is a WhatsApp chat between you and that one friend who's always asking you for advice. So this is your annoying friend who gets up and says, "Bro, I woke up this morning and my eye is red." And before you can do anything, he's like, "What drop should I put?" And then you're still thinking, and he's like, "What are you typing, dude? Like, doctor hi hai na tu? Why can't you tell me quickly?" And then automatically, like, "Okay, what other symptoms do you have?" And I mean, of course, your question is perfectly right. Because what symptoms do you have means that you want to know what is the history, right? But what else do you want to do? I'm guessing that you want to examine. And you tell him, photo bhej, okay, because that's the best you can do on your phone right now. And let's see. The annoying friend is going to send you a picture pertaining to what's happening to him right now. And this is the picture he sends to you, right? So that's a patient. And if you can tell me, what is your differential diagnosis? Anyone who can answer that for me? The fifth sem students, I guess you're doing PSM ENT ophthalm. So perfect. Conjunctivitis. Anyone else? Can it be anything else? Eye. Okay. Okay. So great. Conjunctivitis, pink eye. Can somebody tell me why do you say it's conjunctivitis, not something else? Okay, no take us for that question. All right. I'll ask you an exam question based question. Differential diagnosis of an acute red eye. Seriously here. Okay. Allergic. Allergic would still be conjunctivitis. Trauma is okay, that's different. Chalo, theek hai. We'll go ahead. So, red eye, the differential diagnosis according to your typical textbook. What are you guys using? Khurana, Parsons, one of the two, I'm guessing. So, if you're using either of them, you have one page dedicated to this, okay? And it's conjunctivitis, uveitis or iritis, and acute angle closure glaucoma. These are your three differential diagnoses. But how do you differentiate between the different types of conjunctivitis? How do you know if it is uveitis or glaucoma? Okay, stuff like that. So we go ahead. Now tell me, how is this different from the previous picture? What do you see here? Come on, guys, you guys are here on Friday afternoon. Make it worth your time. Redness more. Yes, it is. Purulent. Isn't it? Perfect. Yes, so what you can see here is a very typical discharge. If you see those little bits where I'm pointing out, if you can see my arrow, yes. So what you can see here is a more purulent sort of a discharge, right? And this is more suggestive, definitely, of a bacterial conjunctivitis. Okay, if you have a bacterial conjunctivitis, what are you going to give the patient? If I ask you to give some eye drops, what eye drop do you prefer? Wonder. Right. We'll come to the treatment. Okay. Erythromycin. Okay. Interesting. Moxie. Yes, gadifloxacin. So gadifloxacin, moxifloxacin are very higher antibiotics, right? You always want to start with something low. You know that there's a lot of antibiotic resistance out there right now. Moxifloxacin, gadifloxacin are things that we want to use for pre-operative and post-operative surgical prophylaxis. So those are not the kind of things that we want to use for conjunctivitis. We prefer something less. A chloramphenicol is a good answer. We also prefer something like ofloxacin or ciprofloxacin. Okay. Now tell me, what are you looking at now? I'll put in a good word with your lecturers if you tell me what you're looking at. Yes, someone go no. Okay. Style. No, it's not a style. Coma. Interesting there. Yes. Okay, could be. What else? Right. So got Wolfenstein trachoma. Trachoma shows a similar picture. You're mistaking something for something else, which is why you said trachoma. Still, you get a few marks for that, right? Vernon, yes, bang on. You're looking at an allergic conjunctivitis, okay? And what you can see there, those structures that you can see there, what are they? Anyone who can answer that? What do you see on the upper tarsal plate in allergic conjunctivitis? Anyone? It's red, a blood vessel flows through it. The top appears to be more red than the base. They also grow a lot, and then you get something called cobblestone something. Yes, papillae. Perfect. So you get cobblestone papillae, right? Cobblestone happens at a much later stage. What you're looking at right here is an earlier stage of papillae, which you will see in the entire spectrum of allergic conjunctivitis. Great, impressed. Now, if you can see, so the textbook gives you a much more precise and in detail explanation for all of these, right? Important really important points to remember between the three of them are: one, viral. Okay, always remember when you get a viral, it's like you get a viral cold. Okay, in a viral cold, even if you even when you have just a nasal discharge, it's always very watery. It's the same way in the eye. You see a watery discharge. Bacterial, you know it's bacterial, so it will always be purulent. And if it's allergic, again, it will be white, stringy, mucoid discharge. It won't be purulent like your bacterial. Okay? And what are you looking for? So you always have to invert the eyelid. Okay? The last allergic picture here is what we saw when we inverted the eyelid. And that's what will differentiate between, say, your allergic and your viral at some point. Because a viral will show you a follicular reaction and an allergic will show you papillae. Now, what are follicles? Can somebody tell me? Okay, tough, but this is also another important question. Between papillae and follicles, you need to differentiate. And follicles are usually more reactive, right? So if there's something happening in your body, this is a reaction to that. So you're going to see like white blood cells and stuff like that. Okay. Uh, Among the history, what you need to know is in a viral, you will have a viral illness, like a viral cold, usually preceding your thing by say 3 to 4 days. A bacterial will typically give you immunopathy and other associated infections. An allergic, obviously, you need to ask if you have any other allergies. You need to know if this person wakes up in the morning and starts sneezing for no random reason and then just stops by himself. That's allergic rhinitis. And you need to examine this person for eosinophilia. Also, the age will be important in an allergic conjunctivitis. Younger kids will have more of that atopic, vernal, spring catarrh kind of a picture, and you really need to treat that. You don't want them to rub their eyes constantly. Okay, and then which is the treatment, obviously. So viral, like all viral stuff, you'll be giving them just symptomatic treatment. Clean your eyes, put cold compresses and stuff like that. Bacterial, you give them antibiotics, and an allergic, you tell them antihistamine drops. We generally give them olopatadine, mild steroid like loteprednol, and sometimes you may also have to give them mast cell stabilizers. Okay, right. Now, what next? Okay. What you should also know in your conjunctiva section is trachoma. Someone rightly said trachoma. Yes, you get follicles in trachoma. Vernal catarrh, again, with children and all of that. You get allergic keratoconjunctivitis, which is also in children. And a very important topic is ophthalmia neonatally. Okay, these topics are too big to go into right here, but these are that you should know, and you should definitely try and read up on those when you get back home. Okay, now tell me, if we are looking at a very similar picture, but if you put a fluorescein stain and examine under the cobalt blue filter, this is what you see. This is a very sort of a surprise picture. So I'm going to give you a few hints, right? Okay, so someone's actually asking me, should be used as a home remedy gentle. Warm compresses and cold compresses. What are the indications for each? Okay, so now generally in most conjunctivitis, we prefer to give them cold compresses. That kind of eases off the irritation that they have and the itchiness that they have. So conjunctivitis, I would say cold compresses. Warm compresses are definitely for stuff like a sty or a hordeolum, basically meaning that there is a pus collection in the upper lid. So if it's sort of extraocular on the lid or the adnexia, we would give them warm compresses. That helps the glands to sort of open up and expel the purulent discharge. So if it's a sty, warm compress. If it's conjunctivitis, almost always cold compresses. Okay. So looking at the picture, coming back to the picture, similar picture. Now the patient is complaining of pain. Okay. And when you stain him with fluorescein dye under a cobalt filter, this is the picture you see. And he tells you that there was some wedding happening at home and I was standing nearby. Or this is a friend calling you from the Alps and said that he has been attempting skiing Or it's a friend calling you from the States and telling you that they went into a tanning parlor or something of that sort. What could this be? Corneal ulcer. Well, it's not. Dehydration, drying of the eye. Well, yes, sort of. But is there any other more particular thing? Welding. So if anyone is, yes, someone saying radiation. Great. What radiation? You've been working in, yes, yes, perfect, perfect. UV rays. What you're looking at is called photokeratitis. Okay, it's going to be a very common picture when you guys become interns and you start working in the casualty. At around 3 a.m., a nurse is going to come and wake you up and tell you, पेशेंट आया है, आंख से बहुत पानी आ रहा है, आंख पकड़ के बैठा है, सिर पकड़ के बैठा है, आंख पे देखो. And even before you go, you're going to tell them after को बुलाओ. Okay, because you're going to know that this is typically one of those patients who has been doing his welding somewhere around evening. He has not worn his protective glasses or eyewear or whatever that is, and he is, this typically occurs a couple of hours after the welding is done, and this is literally a burn on the cornea because of the UV rays that come from welding. Okay, always remember this picture. It's something that you're definitely going to see in your internship, and you can impress your after resident by already telling them photokeratitis ka patient. Okay, right. Now, this is something else. Now tell me, what is the difference between what you see on the left, the previous picture, and what you see here? Now, this is also something that's very common, and a lot of patients will tell you, aankh lal hai for this too. Can anyone guess what that is? Yes, diffuse and localized. Perfect. So, what can give you a localized pinkish reddish in the eye? Yes, it could be a television. Actually, this picture is really deceptive. It can look like a television, but no, it's not. It's not. Anything else? Hint, we've moved beyond the conjunctiva and we are on the coat after that. What are we looking at? Anything in the sclera? Limbal nodule? It's not exactly at the limbal. Pinicula. Good, it could be pinicula, inflamed pinicula. But inflamed pinicula will give you localized, yes, scleritis. So what you're looking at is episcleritis, to be very specific. Scleritis can sort of roughly be divided, and rather inflammation of the sclera can be divided into episcleritis, which is more the very anterior superficial part of it, and actual full-blown scleritis, which can range from a variety of things. So, a basic distinction is when looking at conjunctivitis, you will be looking more at a generalized thing, unless it's a pterygium or pedicula, in which case you get a little bit of inflammation. Okay. In an episcleritis, this form of episcleritis is very common, nodular episcleritis. Okay. You see a small elevation and this pinkish reddish thing all around it. Okay. Generally, you are not going to see this patient with a lot of pain. This patient will be mildly comfortable. It's not too much of a problem. There will be no watering, nothing. It's just that localized redness and maybe a little mild pain. The problem very often this is recurrent. It will keep happening. And one episode you can ignore. But if it's happening again and again, you are going to tell this person to get evaluated for any kind of autoimmune disorders. Okay, you're going to ask them, do you have any joint pain? Do you have a lower backache? Are we looking at a rheumatoid arthritis? Are we looking at something like that? You need a rheumatology workup and an autoimmune workup for this patient, right? Only if it's recurrent. If it's a one-time thing, it can happen to anybody. You may ignore it. Okay, right? So the conjunctivitis versus episcleritis. Rita, yeah, but Rita's has a lot of other stuff too, right? So I'm just giving you a basic episcleritis here. Okay. Now, who can tell me what this is? What can you see on that? This is another common emergency medicine casualty condition. You will be woken up in the night for this also. Final year, guys, come on. Anyone? Floaters. Interesting. Can you see floaters? And are the floaters in the anterior or posterior chamber? Negus. Okay. What is a scotoma, guys? Can you see a scotoma on the? No, no, no. Okay, let's see. And says foreign body.
Ma'am, there seems to be some network issue. Your voice is cracking.
Yeah, yeah. Can you hear me? It's cracking. Okay.
Now
Is
it's
this
better. Now
okay
it's better.
now?
Yes, yes.
Now it's better. Okay.
Oh,
Okay, give me a second. I'll just connect it to. I'll connect it to another network. Maybe that will be better. Hello. You got any
yes, ma'am.
better?
Yes,
Yeah.
ma'am. This is
Okay.
better.
Fine.
Yeah.
Right. This is better. Okay. Fine. Perfect. Right. So what you guys are looking at is okay. What this looks like. Okay. So tell me, which part of the eye are we looking at this on? Where is it? Okay. Iritis. Okay. Which means it is on the cornea. If you notice here, you see this little shadow. Okay. This is a shadow which is being caused by the foreign body on the iris actually. So this is on the cornea. Okay. I picked this picture which is of obviously a light colored eye because you can see it better in this. This is something that you're going to see on a lot of patients. So if you, especially on the patient who says that they were either cleaning or they were outdoor or they were on a bike and they were not wearing a helmet or they were in a very windy area, and right after that they say that my eye is getting really red and getting a lot of irritation in my eye. They come to you trying to rub their eye and very uncomfortable. Okay, if there's a foreign body on your cornea, let's just imagine everyone's had that one eyelash that goes into your eye, right? At some point in time. And do you know how irritating it is? You keep going splashing water into your eyes, rubbing your eyes, trying to get rid of it. A foreign body is like 10 times worse than that. Okay, so it's going to be a very uncomfortable situation. Patient comes to you with an acute red eye, it happens very suddenly and he's very comfortable. Always think of a foreign body. That's one thing that's going to cause a lot of trouble. Yeah. So it's going to be a common foreign body and you will have to remove this. Okay. So an ophthalmologist will typically take a very thin 26 gauge needle and go onto the cornea and scrape this foreign body off, right? And then we're going to put them on some antibiotic eye drops and a lot of lubricating eye drops for the epithelium to heal. Okay, okay. Let's go ahead. Right now, look at this picture. This guy is diabetic. He's 50 years old. He's a farmer. He's not sure if he had any kind of trauma, but he goes to the state every day, and he's in the harvest. Uh, he has lost vision. Okay, he is severe diminution of vision. There is a red eye, obviously. There's a lot of pain, watering, and what you see here, which is a white, yellow kind of a thing. Yes, a fungal corneal ulcer. Any corneal ulcer, but because I've given you diabetic and pharma, yes, you are very right in thinking of a fungal corneal ulcer. Correct. So this is a corneal ulcer. And if this is not looked at right away, and if he's not put on, right away, then it's going to be a big issue, and you are going to end up with a deficiency or a perforation or something of that sort, right? So when we are going to, once we scrape it, we're going to send it for a gram chain. We're going SDA, that's a summer test guard. We're going to send it for a KOH mount. We're going to a bladder guard, okay? And all of these things are and if you think that it's too bad, then you may have to go in and get rid of that problem and put a graft, right? We do a therapeutic keratoplasty, okay? So this diagnosis, which you should never miss, right? Because it really depends. Interesting story about the corneal ulcer was once when I was working at a hospital, and I'm telling you this, you may finish your MBBS and then want to work at a hospital for that time when you're exams and all of that. And if you're a DMO or if you're a casualty officer and you're in the casualty, and something you learn, this is as a conjunctivitis. Now, at least make sure you open the eye and take a look. And then what's happened to me? Someone told me that I was on call, and the casualty officer told me that no, it's a conjunctivitis. It's fine if you don't come. And I'll ask him to see you in OPD tomorrow. This was on a Sunday afternoon, but I'll come in anyway. I'm so glad that on that day I thought of definitely going in and not else a conjunctivitis, because this was much earlier in my career where you don't think of corneal ulcers in your urban setting. You think that this is something that happens to farmers or happens in a cave or something like that, but that's not how it is. Okay, you do get corneal ulcers, and you get them very much in your urban areas. You get them without the patient even knowing exactly what happened. So though with this diagnosis, make sure that if you are in a casualty, you call an ophthalmologist right away. And if you are an ophthalmic resident and if you choose to take it up, then definitely this is one of those really challenging things that you have to do in your career. Okay, so corneal ulcer, one of your TDs. Okay, now I want you to again spot the differences between the picture on the left and the right. Convenience, comment on the congestion. How is it different in the two? It's more brighter and aggressive. Yes, perfect. Ciliary or perilimbil versus conjunctival. Perfect. I'm very happy with that answer. So, what we are looking at on the left hand side, obviously, is your typical conjunctival congestion. And the other side, what you're looking at is a brighter, more aggressive circumciliary congestion. Okay. Now, can you guess what this will be for the other one? You know that this is a conjunctivitis or something like it. But this circumciliary congestion. Uveitis, left is conjunctivitis. Perfect. Can anyone tell me what else can I expect to see in a uveitis? That picture on the right, see anything else? Okay. All right. So what we're looking at right now, light bright red. Okay, it's more pinkish in color when you're looking at it. The other one will be typically described in your books as a dark red or purple. And yeah, I know it's not purple, but that's what it looks like, which is why I've said, just follow the books. And purple and central circumciliary more towards the focus than towards the periphery, right? And that's obviously a deeper redness that you can see. Okay, so very red. That is uveitis, anterior uveitis. Iridocyclitis is another term for anterior uveitis. It's perfect. It's not an iris prolapse. It's just a click of the light there, but it's not an iris prolapse. Talking about uveitis, we are going to discuss anterior uveitis and iritis. But the hallmarks of that is these aqueous cells, right? You're going to have a severe, the patient will complain of severe pain. They'll complain of photophobia. Photophobia, when the patient tells you, लाइट में देखने से बहुत तकलीफ होती है, लाइट में देखने से बहुत दर्द होता है, okay? You are definitely to keep iritis and anterior uveitis as your differential. Why is that? Can someone tell me why they have pain or photophobia when yeah, okay, yes, it is ciliary, yes. And every time that you're looking into the light, what does your pupil do? Does it constrict or dilate? Yes, iris is affected. It is, yes. Okay, it constricts, and that causes a tremendous burden on your ciliary muscles and all that. So, uveitis. Anyone in the first year who's here, tell me what is the uvea made of? Three parts of the uvea. Quick. First years. Years. One who can tell me what is the uvea made of? Ciliary body. Eyes. Yes. Okay. What else? Also, where are all these cells coming from? What are choroid? Perfect. Iris, ciliary body, choroid. And why do we get so much? Yes, that's right. Iris, ciliary body, choroid. Why do we get so much inflammation? Yes, because it is the vascular coat of the eye. Okay, so you have a lot of blood vessels there, and wherever you have blood vessels, when that part of the eye is inflamed, you can get a lot more fluid into your regular ocular fluids, which are supposed to be crystal clear to give you that brilliant vision that you have. So when you see aqueous cells here, okay, those are basically like proteins which are now in your aqueous. Okay, tell me, what does this? What do these aqueous cells remind you of? Can anyone look at that picture? Do you feel like you've ever seen it before? This is a very magnified slit lamp image, by the way. But yes, anything else that reminds you of this guy? Interesting, good imagination. But what I'm looking for, uh, the look of particles of dust in a very tiny. Yes, so floaters occur in the vitreous. Okay, that's the posterior cavity of the eye. Those are because of vitreous condensations usually, and floaters are what the patient sees. Okay, the patient sees some black floating things in their vision, in the field of vision, and those are floaters. What we are looking at is something that the patient will not see. This is what you are seeing when you look into the patient's eye. Okay, and you'll see this typical effect of a ray of light passing through into an empty window or an empty house, and just all those dust particles that move around in it, and those are aqueous cells. What else do you uveitis, right? So when you see a uveitis, you need to look at the corner, and what you're going to see is these tiny bits of stuck to the cornea, the behind of the cornea, right? You can get types of tapes. One is the fine type, okay, which are very tiny, tiny, tiny speckles on the cornea. The second is these huge, big ones, okay, which are called mutton fatties. Keratic plates, again, a short note in most of your exams. So think about it. And why do these occur? I've written it there, but it's a good thing to know. When you get uveitis, it's basically that you're. So what does the aqueous do? It helps the back of your cornea when you have aqueous. It's like having bad water, right? So a hard water will kind of erode on your pipes or your those things. So in the same way, it makes and the parts where it gets deformated, you get all these cells which go and patches and depending on what kind of uveitis you have. So if it's more inflammatory, non-granulomatous effect. But if it's infective, then you're going to get these granulomatous bigger KPs, and they always collect on the corner in this thing called the Arts triangle. Okay, read about Arts triangle is at the bottom of the corner. Okay, the inferior part, and it's a very interesting reason why they collect in the Arts triangle. If someone wants to share it, you can, but otherwise, go and read about it. Okay. Okay. What else do you see in uveitis? What is a festoon pupil? Anybody? Everyone's out to sleep. Okay, no takers for a festoon. Due to synetia, the diet looks irregularly shaped. Yes, correct. So when you have so much inflammatory material, uh, and the fluids are not clear, you have the iris sticking to your lens capsule in parts. Okay, these stuck bits are called posterior synechiae. So when you dilate a pupil, this normal pupil will expand uniformly and turn into another bigger round. But when you have posterior synechiae, as everybody perfectly said, you will get something that looks like that, irregular, because so these bits here are basically stuck to the lens capsule, and these are probably free. So they are trying to dilate, and these guys are holding them back, which is why you get this irregularly shaped pupil. Mm, all okay, irregularly shaped pupil, because of which you get this appearance of a festoon pupil. Okay, what can you see here? This bit at the bottom. Hi. Okay. Okay, it's not a hyphema, but you're close. It's a hypopion. Correct. Okay, that's a festoon pupil, and that is a hypopion, right? These are basically X-rays settle to the bottom of the AC. All these cells, they come down and they settle down at the bottom of the AC. AC is anterior chamber, by the way, and they form this yellowish white line at the bottom. And the higher the hypopion, obviously, the more severe your inflammation is. Okay, so festoon pupil and hypopion. Right. So, what do we do for uveitis? Like, if constricting the pupil and looking at light is causing so much of a problem, and when you know the ciliary body can be involved, you can't have it working so much, constrict, dilate, constrict, dilate. No, we can't have that. We have to relax it. And what do you mean by relaxation? It means cycloplegia. So we give them hometropine or atropine. We keep the pupil dilated so the iris is relaxed. We give them steroids because we want to the We want to reduce this thing or the inflammation. The oral, we have to give them some kind of analgesics because they are going to be in a lot of pain. And then when you have a final diagnosis, for example, again, this can be something that happens in autoimmune conditions, sort of thing, but it can also happen in infections. So send the entire panel of investigations and figure out what's going on with your patient. And one systemic antibiotics if it's an infection, or you may need immune suppressants or steroids or something of that sort for an inflammatory condition. And the most important thing is that you need to be very, very sure that it is uveitis, okay? Because wrong treatment in a case of uveitis or something that you thought of as uveitis could be disastrous, which is why I asked you for another DD. So can someone tell me what can give you this kind of a very painful red eye with circumpondial congestion? One more DD. DD of acute red eye. Anybody? Okay, let's go ahead. Yes, congestive glaucoma. And by congestive glaucoma, do you mean what kind of glaucoma do you mean? What is the correct name for congestive glaucoma? Angle flow. Yes, yes. So I'm gonna tell you, this is a female pain. Okay, severe the eye, headache. There is a drop in vision. She has nausea, and she has already vomited. Okay, and now can you look at this and tell me what could this be? Red as the previous one, but is the picture of an acute angle closure glaucoma. So, female, this can definitely it can happen to males too. It's just that I'm telling you because it's apparently it's more common. But yes, this is the picture of what an acute angle closure glaucoma would look like, and it can be a really, really painful condition. The patient is so uncomfortable, the headache so severe that it causes this severe nausea and vomiting. Okay, so always watch out for them. Again, never dismiss a severely acute red eye. First, never say it's conjunctivitis alone. Never forget it could be something else. But if you feel it's uveitis, double check and triple check to make sure that it's not an glaucoma. Okay. So what you can see here again is a circumciliary congestion, a mid-dilated pupil. I hope you can appreciate the difference between this pupil and that pupil. Okay. So in uveitis, the picture that I showed you in the beginning, I'll go back to it. This picture, this is a pharmacologically dilated pupil. Okay, this is not a natural pupil. This is a pharmacologically dilated. It is under atropine of homide, but this pupil is a naturally slightly dilated pupil, and this can occur in an ankle closure glaucoma. Okay, you will see that the anterior chamber is very shallow. What's the anterior chamber, guys? Can someone tell me? For the younger kids, what's an anterior chamber? Okay, two structures that basically form the anterior chamber. If the anterior chamber something looks like this from the side, then what is this? Yes, yes. Great. You've already got the answer. It's basically lens capsule to endothelium. Okay. That's actually the, yeah, that's anterior segment. Anterior chamber is between the cornea and the iris. Yes, correct. This is an acute angle closure glaucoma. Okay. This is an ophthalmic People think there are no emergencies in ophthalmology, but guys, that's not true. I just showed you so many. Okay, these are all emergencies, and this is one of the really acute emergencies because your patient will be very, very uncomfortable. The intraocular pressure, if you check it, will probably be somewhere in the 40s or 50s, which is a very high pressure. Someone who can tell me what is the normal intraocular pressure? Normal intraocular. 10 to 21 is correct, right? So all of you guys who said 20, 21, remember, like all things normal, it's a range. The WBC count is never 5,000. It's always 4,000 to 11,000, correct? Same way, intraocular pressure, it goes from 10 to 21. And 50, obviously, is super duper high, okay? So when you have something so high, automatically a patient is going to be very uncomfortable. There is always a risk of loss of vision. Why? What does high intraocular pressure do? Or what does any glaucoma do for that matter? Which part of the eye does glaucoma affect? Yes, optic damage, correct, optic nerve. What specific in the optic nerve? Yes, it puts a pressure on the optic nerve. It's not optic neuropathy. Yes, it is affected, but yes, ganglion cells. Perfect. So the ganglion cells are affected and they undergo apoptosis. Okay, in glaucoma, and in an acute angle closure glaucoma, it happens at a very fast rate, right? So what we need to do is we need to bring down the IOP. Okay, we need to bring it down. And how are we going to do it? We're going to do it with IV mannitol or tablet acetazolamide or some kind of eye drops. Now, in uveitis, what did we want to do? Dilate the pupil and relax. In this, we need to constrict the pupil because your anterior chamber, which is bound by the iris, is very shallow. Okay, it's like this. Iris away to open up the chamber, and that can be done if you constrict the pupil, right? Then you want to give them analgesia, nausea, maybe later do a peripheral iridectomy, which opens up a hole in the iris and allows the aqueous to flow out more. Okay, right. So basically, look very carefully. If you see a painful red eye, please make sure you differentiate between uveitis and PSEG because the treatment differs completely. And if you make a mistake, you're going to worsen the patient. Yeah, right. What is this? We'll go to easier stuff. That was heavy. So easier stuff now before we wind up. You can tell me. This is also another aankh lal hai. Okay. This is say hypertensive patient. Ye mummy ki aankh lal hai. Yes, could be trauma. What is the condition for? It can happen because of a blunt trauma. I agree. What is the condition for? Another hint: hypertensives will also get it sometimes. Oh, no. Retinal? No. Is the retinal front of the eye? Can't be retinal. Hemorrhage. Yes, it's a subconjunctival hemorrhage. Okay. So let's imagine that if I took a blunt object and hit you really hard on the hand, okay, and or you just fell. I don't want to hit you. Just fall by yourself, and maybe you hurt your knee or something like that. What do you get? You get a bruise, right? And you get some kind of like a hematoma sort of a thing. It looks very reddish in color. Why does that happen? Because your skin is not transparent. That's also collecting under your skin somewhere. Here, your conjunct. So when there is either trauma or a small capillary in the eye kind of gives way or something of that sort, the blood extravasates. It kind of fills up under your conjunctiva. But because it's a transparent structure, you see bright red kind of a thing over there. Yeah. This bright red uh, lesion is called a subconjunctival hemorrhage. It can happen for no reason at all sometimes. It can happen if someone just rubs their eye too hard. It can happen if the patient is the BP is shot up. And it can happen if there has been some kind of a blunt trauma to the Okay, not much that needs to be. Show your patient, tell them 10-15 दिन में चला जाएगा. You don't have to worry. You can give them some vitamin C to just help it, work faster. Cold compression to stop it from getting worse if it's actively bleeding or it has just happened, and your patient should be fine. Right now, something that you guys all must lockdown. All of you are doing online classes. Everything is on YouTube. It's on not. And so this is for you as well as for your patients. Very common cause of red eyes, along with some grittiness, long hours on the computer. You will get a lot of patients who come to you with these complaints, especially engineers. Okay, all your software IT people will come with this, and this is computer vision syndrome or digital eye spot. Okay, so very important. Make sure that your computer screen is lower than your eye level. Make sure straight and you don't slouch at all. Make sure that your lighting is good, that your hands are placed correctly, 90 degrees. There should be some padding below your wrists, and all of this. So this is an image that I've created for my patients, but feel free to look at it and incorporate it in your everyday life, because we are probably going to be doing a lot of online stuff now. So we all need to know what to do, right? Another cause of red eye, but it's a more chronic kind of a cause. Okay. That brings us almost to the end. I think I've covered a lot. That's basically what I want to tell you. There's more to a red eye than what we just think of for our exams. Okay, it can really go to a number of things, and ophthalmology as a super interesting, because whenever you're going to learn ophthalmology, if you ever choose to take it up as a career, the best part is that you can see a lot of things just on the slit lamp. Okay, so many things are, so many investigations that you can do, and yeah, basically you can come to a diagnosis by actually looking at stuff. You don't have to go in, you don't have to put an endoscope and stuff like that. Your slit lamp much for you, right? And the ingredients for a good diagnosis, not just in this case, but in any case, is great history taking, absolutely thorough examination, and a willingness to look beyond, just those little things that we think memorize as notes, but look beyond that and really think of what else can be happening to your patient, especially to your teleconsultation annoying friends who will keep texting you, asking you, or kya. So kind of people. And yeah, that brings us to the end. Be anything. So if anyone ever asks you that I have a red eye, take a more detailed, history and ask them to send a better picture, and definitely send them to an ophthal friend who can help you out with this. Yeah.
Okay. Thank you so much,
Yes.
ma'am. That was a lovely session.
Thank you.
Now
Thank
we'll
you.
be open for some question and answers from the
Sure.
audience. If you all want to ask any question, you all can unmute yourself and ask, or you all can type it out in the chat box if necessary.
Yes.
Hello. Good evening, ma'am.
Hi. Hello, Tanya.
Hi. Actually,
Hi.
ma'am, there's a picture on the screen right now, and I forgot the name of the pupil in the last picture. What do we call that?
Festoon. Festoon. Festoon pupil.
Okay, thank you, ma'am.
Occurs in Uveitis. Which year are you in?
I'm in second year, ma'am.
Second year. Great. So you'll be reading about this very soon then.
Okay,
Yeah.
ma'am. Thank you so much.
Yes.
It was
You're
a lovely
welcome.
session.
Thank you. Thanks, Bhavya. Thank you. Anyone else? Okay, tell me, have I inspired anybody to become an ophthalmologist? Brownie points if you say yes, yeah.
It's an
Yeah.
interesting field, and actually, I would like to go ahead and study more about that.
Yeah,
But
yeah, you should.
yes, ma'am. And
Yeah,
actually, because
you are
of this
an
session,
MBBS, no? Yeah,
yes, ma'am.
when you are an MBBS, you don't get to see a lot of stuff, because everything is, we need a magnified vision for everything, right? So you have to look through the slit lamp, and maybe that's why you guys don't see so many ophthalmology cases as you would see a gynae or a surgery or a peds, because they are so much more bigger. So I hope that these pictures, which are all slit lamp pictures, kind of give you a view into the eye as you don't see it normally. Thanks again. Right. Any questions?
I think this session was very interesting
Great.
because
Thank you.
we got a lot of clinical exposure as to in real life how we see patients, how how to approach them, and how actually to avoid questions that usually people ask us as medical students. It's
Yeah.
been actually a good road, man.
Thank you. Thank you. I'm so glad you enjoyed.
Yes, ma'am.
Right.
Okay,
Okay.
so before we end the
Yeah.
session, the link for the post-event form has been posted in the chat box here. You can go ahead and fill it out. And we together at the SAC and the Rotaract Club, thank you, Dr. Neha ma'am, for
Thank you
giving
so
us and
much.
bringing us such a interesting session. And we look forward to doing more sessions with you.
Sure. Happy to. I'm so glad. Curiosity, is this something that you do, like outside of your routine college lectures and all of that? Is it?
Yes,
You
ma'am.
guys invite
This is
people to speak?
outside of the routine.
Oh wow.
Yes,
Wow.
ma'am.
Perfect. I'm very impressed that you guys want to do something like this. It's really nice. Yeah. And be happy to
Thank you.
help when I can. Yes. Thank you. Right. I think we are done. Do I have to fill out this thing too?
No, ma'am.
No. Okay. Fine. Great. Oh, thank you so much. Then, if
Thank.
there are no other questions, then I think we can end.
Yes, ma'am. Sure.
I hope I didn't bug you guys too much. Right.
Yes, ma'am.
Yeah.
No problem.
Okay. Yeah, I can
Thank.
email ID if you need something.
Yes,
Do you
ma'am.
want me to type it out here?
Yes, ma'am. Type it in the chat box.
Yeah, there. Okay. Yeah. So you can, if there are any questions, you can always email me. Yeah.
Yes, ma'am.
All right.
And for those who have
Yeah.
missed half of the session will be available on YouTube because it's been recorded the whole time, so I can watch it anytime if you want.
Okay. Great. Perfect. Thank you.
Yes, thank you so
Yeah.
much, ma'am. Lovely to have you.
Bye. Lovely. Thank you.
Bye,
Bye.
ma'am. Thank you.
Bye.
Bye bye. We'll be keeping